The previous talks make me personally feel much safer in the valley. It was amazing. Thank you. It makes me especially safer going into the next ski season. So the last one, I hope you still have some stamina to help me get through these slides. I'm Dr. Seifarth, and I work at the newly opened Montana Children's Facility down in Kalispell. This is actually looks like a rendering, but it's a real picture of our new facility. And I invite you to come over and check it out. It is state-of-the-art, it is amazing, and is dedicated for children and their families coming from all over the state. I work with more than 40 pediatric specialists. I want to point that out because 3.5 years when I joined the Valley and helped building this program, we were a handful of providers. And within 3.5 years, this hospital was able to attract an incredible talent, providing highly specialized care to children. We work closely hand in hand with 100 primary care providers, and the new children's facility has a 12-bed pediatric unit and a 6-bed pediatric intensive care unit. This doesn't seem to be large, but is the biggest and most specialized facility in the state of Montana. We currently have a 12-bed brand new neonatal intensive care unit with a shelved space for 6 beds, so we can accommodate 18 babies needing intensive care. All that wouldn't work without specialized staff, starting from nursing, but not just nursing, as Jason Cohen has mentioned. It starts from the food. It starts from everybody who is in that facility providing care for families. That means their parents, grandparents. We have sibling spaces. We're building one of the most amazing playgrounds you will see, and not only in Montana, but any children's facility. And we are super excited about this. So this whole building is a work in progress and is designed to serve children and their families, and not less for providing a great space for everybody for us to work there. So this is designed to be maybe a little too much on one slide, but it should represent and show you what we currently have in the Valley. So we have all these specialists that I show you are covering 24/7. Child and adolescent psychiatry, neonatology in the brand new NICU, pediatric anesthesiology. We are the only facility in the state of Montana who provides 24/7 pediatric anesthesia care. That is unique and means that you can come at any point of the day or night and you will have a specialized provider for a baby or a child going to the OR. We have pediatric cardiology, dentistry, endocrinology, specialists for thyroids, for example, diabetes, pediatric gastroenterology. Pediatric hospitalists are specialized pediatricians who provide care on the unit, hand in hand, collaborating with the primary care providers in the community. Maternal fetal medicine is a very important part of any children's hospital because pediatric care starts in the womb. We are seeing parents with babies that are unborn and prepare them for the care, and we currently provide tours in our neonatal and intensive care units to make them feel in good hands and show them the environment. Pediatric neurologists or nerve specialists. We have the only pediatric neurosurgeon in the state, pediatric eye doctors, pediatric pathologists. This is incredibly important. A pediatric pathologist is a specialist who examines all the specimens, all the tissues that we take out. It's incredibly important for cancer care, for example. Pediatric radiologist, and we will see some pictures of that. And last but not least, pediatric surgeons. So all of that would not work in a silo. We all are interdependent on each other. And this is what it takes to provide highly specialized care. So let's start. I would like to present to you one patient who's benefiting from different specialists and our in our facility, and which wouldn't have been able to be treated here without these specialists being here. So this is baby Torin. He was a happy, full-term baby boy, happily feeding, no issues whatsoever, until he turned 4 months of age. At 4 months, parents noticed he was vomiting, he was more fussy, he was refusing feeds. Something was clearly not right with him. And I'll show you some pictures. He was eventually referred to a pediatric gastroenterologist, Dr. Lustig. And the question was, is this just a normal stomach flu? It seemed to be much more than that. And I'm glad for Dr. Means' talk, because you will remember his talk when you see some of these slides, and I don't even have to tell you what it is when I show you the slide. So what Dr. Lustig did, he started a contrast study. So this is baby Torin after getting sick. You don't have to be a doctor. See, he's really not doing well, and there's a reason behind that. That must be more than just a normal stomach flu. So that's the picture of a contrast study. In this X-ray, you see the heart, the chest, and black is content in our bowels. So they let baby swallow a contrast, a liquid that can be seen on X-ray, and as you notice now from before X-rays, that should all be down here in the belly. So what does that have to do up here in the chest? The X-ray shows similar results. On this X-ray, you see that fluffiness here. On that side, the chest is black. Black is air. Here you see fluffy, like dirty appearance of the X-ray, and I also brought you a normal one. I don't see enough. That's much better. So here you see a normal X-ray, heart, diaphragm, and here's a lung, and here's a lung. So there's clearly something in that chest that doesn't belong there. So this is an example of a diaphragmatic hernia. A diaphragmatic hernia is a hole in the diaphragm. Here you see a normal baby with lung, heart. The diaphragm is that muscle that divides the tummy from the chest. And here, and that's Torin's case, you have bowel loops pushing up into the chest. And look at the heart. The heart should be in the middle. The lung should be freely having enough space to inflate with air, and everything is squished to the right here, because that entire bowel that is up in the chest is pushing all these vital organs to the other side. You can imagine this can be a quite dangerous finding. So how did he make it so long? And we talk about this a little bit later. Here's a picture of the diaphragm. I think diaphragm is flank steak in a cow. So it's a thick muscle that divides the chest from the belly. And here you have a view on the diaphragm from the belly. Here's a hole. That's the hole that Torin had. And he was born with that hole. That's what congenital means. It's a birth defect. Diaphragmatic, it's the diaphragm hernia. There's an opening here. And through that hole, the bowels made it up into the chest. So congenital diaphragmatic hernia is quite rare. It happens in about 1 in 2,000 babies. To give you an idea, we have about 12,000 babies born in Montana each year. So this happens 5 to 6 times a year in Montana. And it is that defect, that opening in the diaphragm, that gives the bowels rise to slip into the chest. And not only the bowels can be up there. Dr. Means showed you that huge spleen. It's very common that a piece of the spleen slips up into the chest, or a piece of liver. That per se is not dangerous, but the compression of the lungs and the heart, which makes this a potentially dangerous finding. Thankfully, this is frequently diagnosed before babies are even born. We see that on ultrasound, and can prepare babies and mothers for early treatment. It is very rare that this is diagnosed after birth, as it causes very frequently respiratory distress. It means that those babies cannot breathe well. They are born, even if it's missed and not seen on ultrasound, many of these babies cannot breathe well, and it's very early recognized. So in Torin's case, he had a small opening, and these bowel loops made it slowly up in the first weeks and months of life and accumulated and got stuck in that chest. And that's a very rare finding that it's diagnosed later in life. And these babies present, like he did at some point, with obstructions, meaning the bowels are stuck. The food cannot make its way all the way down to the anus through all the bowels, and they start throwing up. Or they have breathing issues. He had less breathing issues than these GI issues. So the therapy of that finding is surgery. The concept is very simple. Bowels down, close the hole. It requires a large team, and these are just a few of the specialists that are involved, but many more are important to make this entire treatment successful. Of course, it requires pediatric surgery. Dr. Falk and I operated this baby. It requires a pediatric anesthesiologist, and some people say, the pediatric anesthesiologist would say, this is more an anesthesia problem than a surgical problem, because surgery is quite fairly simple. Close the hole. But to keep a baby stable during anesthesia, providing it with air, pushing enough air into the lungs to keep them expanded, and at the same time helping us to have enough space in the chest to fix it, that is an art. Of course, once the baby's operated, Torin went to the floor. He was on a team with pediatric providers, hospitalists, and the entire OR wouldn't work without specialized people who know how to treat small and large patients. That starts with putting an IV. You can't imagine how difficult it is to put all these tiny, tiny lines. Dr. McGill showed that central line. We have all the same thing, just on a miniature scale for babies. So I'm going to ruin it. Dr. Means was more respectful. I'm going to show you a video. So in TV, they say viewer discretion is advised. So if you cannot watch, please don't look. So here's Torin. This is his back, this is his front, and these are trocars. These are cannulas that go into the chest. The instruments that we use have a 3 millimeter tip. So most of the surgeries that you see are happening in a scale of a walnut size. Here you see a chest from inside, and full disclosure, this is not Torin. I put a mix of 3 patients together, which essentially all have the same. Here you see how these bowel loops, these are all bowel loops. Hunters know that from deer. We look the same inside. This is Torin's chest here. All these bowel loops, the chest is filled with bowel loops, and I don't even see the lung. The lung is out of the picture. The lung is smushed up in the upper portion. So with these chopstick-sized instruments, we squeeze everything in the chest down, and what you see here is a piece of liver. So this was a patient that was not Torin who had a piece of liver, and I want to show you what can all be there. So we squeeze everything as gentle as we can down into the chest. The liver piece here is the last portion. Spleen or liver is frequently up there. Till everything is down. These capsules are very fine, so the risk is here of injuring it. This is the end result of Torin's replacement, where all the bowel is in. This is the defect. The defect here is about 5 centimeters large, and this meaty area is the diaphragm. Here you see that the rim of the diaphragm is freshened so that the sutures can hold and that the area can heal better. In the next video sequence, this is the Torin's almost completed repair. Here I want to show you how that's been done. These instruments, again, are about 3 millimeters wide. This defect here, just to give you an idea, is about the size of your fingernail of your thumb. So what appears clumsy or shaky is the result of having a 10 times magnification, small instruments, and we're looking at a very, very small space. Every little tremor of your hand is seen here as a jerky movement. To give you an idea, this patient here, Torin had about 5 to 6 stitches. These are little pledgets, tissue pieces that prevent the sutures from cutting through the tissue. These 5 stitches take about an hour. Maybe somebody can do it faster, but for me it takes an hour. So it takes time. It's a very, very tedious, fine procedure. And I heavily edited this. There's times where there's a spaghetti amount of suture in the chest. But you get an idea on how this suturing is happening inside the cavity. Here, see how the ribs look on the inside. So let's look around. This is the diaphragm. Here are the ribs. And this here, down here, you see is the lung. That is a smushed lung that is retracted, A, because it's small. It couldn't develop well with all these bowels in the chest. And B, we insufflate gas, CO2, into the chest to give us a space to work. That's the principle of every minimally invasive belly or chest surgery, to create a space by insufflating a gas and blowing up the space to enable us to work. Here you see the lung. That is a lung that the anesthesiologist has to control not to overinflate. If they blow air into the airways from above, we cannot work. And this is the end result of one of these stitches, and this is how a repair looks after completion. Oh yeah, that looks clumsy. We can stop that. Okay, so here's the end result that is torn. We have essentially three, those are about 4 millimeter incisions. We use absorbable sutures that all dissolve. So we can go back to the slides, please. Oops. Died. There we go. So after this operation, Torin was back to his old happy boy essentially within 24 hours, and he was discharged the next day. Here, a little skeptical shortly after surgery, but this was after eating, and this was within 24 hours. And not only Torin's happy, Mom's happy. And let's recap. This was his x-ray before, and you see these, now you can know what these are. These are all the bowel loops accumulated. This is an x-ray after surgery, and if we follow that line, that's the diaphragm that is repaired, and the lung is nicely re-expanding and getting back, taking back its space. Look where the heart is. The heart is all pushed over. That's the heart. And the heart went back nicely into the middle. That's Torin a few weeks later. We're proud of that. This is the reason why we do that minimally invasive, to have him recover fast, and of course also to enjoy smaller incisions. This was Torin a few weeks after surgery, about a month ago. And I don't know if Torin is here. Pictures, they say 1,000 words. Is he up there? Yes. Hello, there's Torin. Please say hi. Thank you so much for coming, Rebecca. Because you guys are the reason why we're all here, and we want to thank the hospital, the community, to make this happen, to allow us to work in this great, great place, to build this space, and to provide care for these little babies and our patients. So thank you very much for coming tonight.